I'm excited for our next speaker. I will just share with you that there are many times we received a lot of questions about dementia, Parkinson's dementia, Lewy body. It's very confusing and it's a very big concern. And we have a wonderful movement disorder specialist from the University of Michigan, well respected in his field, a wonderful provider, Dr. Kotagal. Thank you. Thank you so much. There's this too. If you like it.
Thank you. Thank you.
This is good.
Looks great. Thank you, everyone. This is an amazing event. I've been to a few events by NPF before, but I'm sort of floored at the scope and size of this particular event and the number of people here. Julia, Kristen, and the whole 9-person NPF team, great job. So I was telling Dr. Dorsey earlier today after his talk that he's a hard act to follow. I felt empowered and really ready to go out and, do something physical after he was done to just kind of take ownership of this. My topic's a little more sobering, but I do want to engage the audience to think about a particular act relative to this topic, which is that look at the slides that I'm going to present and think about the content that I'm going to present in a skeptical way, because a lot of what I will tell you speaks to huge knowledge gaps in the field surrounding dementia, dementia risk, what causes dementia in Parkinson's disease, and the words we even use to describe this condition. So I don't have any financial conflicts of interest to disclose. This is kind of an outline of what I'll be talking about. I'll talk a little bit about, like Julia mentioned, some confusing terminology related to Lewy bodies and Lewy body dementia. I'll try to talk a little bit about cognitive impairment and the concept of dementia in Parkinson's disease, dementia with Lewy bodies, which is sometimes called DLB, and I might slip into calling it that, and then FDA-approved treatments that exist currently. So first of all, what's a Lewy body? Frederick Lewy was a neuropathologist in Europe 100 years ago who actually was doing his training in the lab of Alois Alzheimer, another neuropathologist whose last name became associated with a common neurologic condition. He identified in post-mortem autopsy samples these sort of envelopes filled with pink, filled with pink content on staining that are shown as this circle that the arrow is pointing to there within nerve cells, and didn't know what was in them, and they became known as Lewy bodies, named by his colleagues after him. Decades later, we began to learn that there's a specific protein that's inside those envelopes of pink eosinophilic staining in cells. And that protein is alpha-synuclein, which is a normal protein that we make normally and use in our nerve cells to transmit messages from one nerve cell to another. But in the context of Parkinsonian conditions, alpha-synuclein doesn't get cleared through our normal quality control mechanisms in cells. It starts to build up, create globs, and they get sequestered into those Lewy bodies. Lewy bodies are pretty common in age-related studies. A lot of these studies depend on autopsy or post-mortem data because we don't have a test in life that can tell us about whether somebody has a Lewy body in their brain. So we are dependent on end-of-life science to try to understand this, but about 15% of people without cognitive impairment in their 80s walking around have Lewy bodies. And about a third of people with dementia, irrespective of what's causing the dementia, have Lewy bodies. So Lewy body disease is a word I hear a lot. Technically, this is not a clinical term. It's a neuropathological term that refers to the presence of Lewy bodies under the microscope. This term, however, has grown in popularity because it allows us on a scientific level to just talk about the fact that there's a whole family of different clinical conditions, all of which have Lewy bodies in them. These all have different names: Parkinson's disease, multiple system atrophy, dementia with Lewy bodies. Sometimes the combination of Parkinson's disease with dementia and dementia with Lewy bodies are called Lewy body dementias, or LBDs. LBD is the same abbreviation you could use to describe Lewy body disorders. You can see how all these words just start to have confusing overlap. I think the key thing to note is that Lewy bodies are unusual, and they characterize a broad set of disorders that are interrelated. And if we can figure out how to treat the causes of Lewy body development, we can improve all of these conditions. Another term you'll hear is alpha-synucleinopathy. Apathy meaning disorder, and alpha-synuclein meaning that protein that I spoke about earlier. So about 25 years ago, there became increasing interest in how Lewy bodies spread throughout the brain. You may be aware that there's something called the Braak stage hypothesis of how Lewy bodies develop in the brain. So this comes from autopsy data in Germany that looked at individuals without any Parkinson's conditions and individuals with Parkinson's conditions, and found that, interestingly, there's a very specific order in which Lewy bodies started to be formed in the brain. It would start in the deep parts of the brain, shown, I use my cursor here, shown over, well, it's not really showing up, but shown in the deep parts of the brain, and would spread up to the midbrain. At that point, the substantia nigra would become affected, and that's stage 3 of 6, and that's when people would start to develop motor features of Parkinson's disease. And then later, the more cognitive thinking parts of the brain would become effective. And in theory, that's when people would start to develop dementia or cognitive problems. That initial plan got a subtle addition to it, which with attention given to the fact that Lewy bodies can also initiate in the olfactory nucleus. This has led to a series of hypotheses over the years about different subtypes of Parkinson's disease and whether different people may be at different risk of dementia based on where the Lewy bodies first begin. These days, an often invoked hypothesis in Parkinson's science is that some people develop body-first Parkinson's disease that starts in the GI system, and other people develop brain-first Parkinson's disease. I'm very interested in this. I'm very interested in working towards a cure and finding out what causes Parkinson's disease. With that said, wearing my scientific skeptic hat, I think the evidence is pretty limited at the moment to support the idea that these are two different conditions that have different pathophysiology. I'm a lumper, not a splitter in this context, and I think these are all just different manifestations of a complicated condition we call Parkinson's disease. So I mentioned there's PD, I mentioned there's dementia with Lewy bodies. Dementia can develop in PD, and sometimes that's called PDD, or Parkinson's disease with dementia. Sometimes dementia can precede Parkinson's disease and can precede the motor symptoms of Parkinson's disease. And in those situations, we call it DLB, or dementia with Lewy bodies. Is it important that you know the differences? Not instrumentally. The medicines that we use are still the same medicines in either condition, but I think people want to know, what does this mean for me prognostically? And I want to just kind of highlight some of these things up here. So key differences are that motor Parkinson's features start earlier in Parkinson's disease than they do in DLB. Some non-motor features are a little bit more common in DLB. So sleep problems and mood problems and psychosis are seen more commonly in DLB. Dysautonomia, or things like lightheadedness upon standing, is more commonly an early feature in Parkinson's disease. People with DLB often have other coexisting things happening in their brain as well. We call them neuropathologies. And DLB tends to occur slightly later in life compared to Parkinson's disease, where in the US, the median age of onset is around age 61. This is a busy figure. I'm going to skip it in the interest of just not belaboring this, but Parkinson's disease is what happens when the motor features start early and then dementia develops later, and the opposite is true for DLB. So cognitive impairment itself is common in Parkinson's disease, but it's not always so severe that we consider it to be fitting with the term dementia. Early cognitive features are seen in around 30 to 40% of people with PD, and they don't necessarily serve as a harbinger for who's going to develop dementia over time and who's not. The bottom bullet point here makes the point that in really careful, rigorous studies, dementia seems to affect just slightly more than the majority of people with Parkinson's disease if followed for a long enough period of time. That's a really confusing piece of information to digest, because it doesn't mean that everybody's going to get dementia. It doesn't even mean that 80% or 90% of people are going to get dementia. Some people will and some people won't. And if we all have the same disease, why is that the case? This is one of those knowledge gaps that our field needs to unpack and figure out the underlying cause of. This is a schematic of kind of the natural history of Parkinson's disease, and it informs how I think about dementia, at least, and so I want to walk you through it. The horizontal black line there represents time moving in that direction, or disease, time with disease, and the vertical black line represents the time of diagnosis. So you can see there are some symptoms that develop prior to the initial diagnosis of Parkinson's disease, like an impaired sense of smell or fatigue, olfactory dysfunctions listed here. LIDS stands for levodopa-induced dyskinesias. Hoehn-Yahr stage 3 stands for the development of balance difficulties, freezing of gait, and then dementia develop over time. That orange dotted line that's inching its way up there represents increasing disease burden as time moves on. And dementia is one of those things that tends to, in Parkinson's disease, tends to be thought of as a staging element because it comes after the development of many other features before it, but it's by no means a certainty. Many people have Parkinson's disease for years or decades and don't develop dementia. We don't fully understand the reasons for why that is. So mild cognitive impairment is the term we use to describe when people have early symptoms of cognitive changes. They're noticing something is different, but it's not impairing their ability to care for themselves substantially or look after their daily affairs. It's pretty common in Parkinson's disease early in the condition, and it can cause a wide variety of different symptoms. Some people can experience difficulties with attention or multitasking difficulty. In rare cases, early in the condition, people can sometimes also experience visual spatial dysfunction, which are, can manifest with missing a chair when you're trying to sit down or bumping into a wall when you make a turn. But pretty common, at least in my own clinical practice, is people saying, why did I come into this room again? What was I doing with this thing? Where did I leave that? It's challenging because I experience those things too. These are all just also part of normal aging. And so it becomes difficult to understand what's the interface, but what's normal aging and what's pathological aging in that setting. On a research level, we have what are called diagnostic criteria when we do studies of mild cognitive impairment, and these are fine. They involve, you can see they involve a lot of words. They are nothing special though, and I think I want to poke holes in these criteria just a little bit here. So they basically say that, well, if we're trying to understand the biology of this condition, we want to make sure that we're studying people with Parkinson's disease who have impairment on cognitive testing, but we also want to make sure that their impairment on this testing and their impairment in general isn't due to other things that can affect cognition, anxiety, depression, sleepiness, other mood changes. And that's a very idealized notion. Most people with Parkinson's disease have all these changes have some of these symptoms because of the exact same brain changes that are causing cognitive impairment. So as a scientific field, we have a imprecise and somewhat inaccurate way of defining mild cognitive impairment. I think that's one of the reasons that we don't fully understand the biological basis for it. Either we restrict our studies to people who are a very narrow subset of people that don't truly represent everybody in this room who might have Parkinson's, or we make it so general that we're not studying Parkinson's disease at all. The brain biology that's thought to occur and underlie mild cognitive impairment in Parkinson's disease is thought to start in the deep front parts of the brain, parts that receive some dopamine from the substantia nigra itself. Dopamine feeds different parts of the brain, including the multitasking components of the prefrontal cortex, reward mechanisms in the ventral striatum, and memory in the hippocampus as well. This is a survival curve from an incident study, incident Parkinson's disease study. These are terms that mean something to researchers, but I'll try to unpack what I mean exactly here. So a lot of times when people come to be involved in Parkinson's research, they've had the condition for 2 years, 5 years, and they sign up for a study. And even if they're followed for the next 10 years afterwards, it's hard to know whether, let's say, 10 years into a study, they develop dementia. Did they develop dementia 15 years after that disease truly started? Was it 18 years after the disease truly started? A lot of the times on the front end, we don't really even know when the first symptoms started, because before somebody got diagnosed, nobody was monitoring them with annual physical exams to look for subtle changes of Parkinson's disease. This confounding factor exists in a lot of what we understand about the natural history of Parkinson's disease. So in few cases, there have been what we call incident Parkinson's studies. So in Cambridgeshire, United Kingdom, they have a careful study involving the 20 primary care clinics that are affiliated with their National Health Service in that area, in that county basically. And they've shown that if you, from the very earliest time of Parkinson's disease onset, the risk of developing dementia after about 10 years, if you're getting regular follow-up, it's about 50-50. It's not more than that. And this figure, this line, is as the line drops down to the bottom of the figure, that's the risk of dementia being present in 100% of individuals. And you can see it's leveling off there around 50-50 at 10 years from the time of diagnosis. So on a biological level, the same group has put forward this hypothesis called the dual hit model of dementia, where they say, well, early Parkinson's disease, that's a dopamine-focused condition that causes difficulty with multitasking. It causes difficulty with paying attention and some memory stuff. But people who develop dementia often develop it in the setting of a hit to a different part of the nervous system, a hit to the back part of the nervous system that deals with visuospatial reasoning, sense of identity, sense of self, and hallucinations. And that maybe you need hits to both parts of the nervous system, either through Lewy bodies or through other things that can affect the brain, like vascular brain injury or early Alzheimer's pathology that gives rise to this over time. I put up a busy slide before about the research diagnostic criteria for MCI. These are the research diagnostic criteria for Parkinson's disease with dementia. The bottom part of this table is cut off, but I'll kind of explain part of what it is that you have to have a bunch of different boxes are checked based on cognitive performance, but you can't have depression as one of the underlying causes to meet criteria for Parkinson's disease. It's kind of a messed up criteria. It's not really a well-suited criteria for a condition that causes depression in a big chunk of people. This leads to a misunderstanding of what's actually driving cognitive impairment in Parkinson's disease. But these are the current existing clinical diagnostic criteria for PDD. So just to take a step back in our sort of telescopic view of this all, Parkinson's disease itself affects about 1.2 million Americans. Dementia with Lewy bodies, this related condition, affects at least as many Americans, about 1.4 million Americans. It's maybe the second most common cause of dementia in aggregate. You can see on the pie chart over here that these two conditions are depicted in the green portion of this pie chart. Cerebrovascular disease is loosely depicted as the second most common cause over here, but this often just coexists with the other conditions and may not be its own discrete condition. So compared with PDD, DLB shows a higher rate of hallucinations, delusions, and paranoia. DLB has its own diagnostic criteria. I'll skip this in the interest of time, but a neurologist named James Galvin in Florida has done a lot of looking into DLB and trying to understand the lived experience of people and family members who who take care of people with DLB. And one of the most striking things about this condition, to me at least, is that most people see more than 3 doctors before they get a diagnosis. And most people have more than 10 visits, not necessarily with a doctor, but with a medical care provider trying to get to the bottom of this before they actually get a diagnosis. People are often given different diagnoses, mental illnesses, Alzheimer's disease, sometimes Parkinson's disease, before they arrive at a proper diagnosis of DLB. This is, again, I want to highlight this as a knowledge gap. If we feel that the best time to prevent a disease is before it starts, but we're not good at actually diagnosing a disease, it's very hard to develop treatments that prevent the disease and test them in people who might benefit from them. So this is another knowledge gap that needs to be solved in order for us to affect this. So what treatments are out there for cognitive impairment and dementia and Parkinson's disease? Well, cholinesterase inhibitors are the most common type of medication used for this condition. They have good medical evidence in Parkinsonian conditions, including PD and DLB. They show an improvement in overall functional impairment, people's ability to take care of themselves, as well as features like hallucinations and multitasking. These are drugs or medications that are either oral pills or can also be given in transdermal patches. Another common clinical management step are to use medications that we call antipsychotic medications to improve delusions, paranoia, or psychosis, which are less common than mild cognitive impairment, but are much more disabling than the mild cognitive symptoms, both for the individuals themselves and for their families. There are a few classes of these meds that really can be quite helpful, but and do not worsen other aspects of Parkinsonism, but there are a number that actually can worsen other elements of Parkinsonism, and this is one of the utilities of following with a neurologist is just a detailed review of medications to make sure you're not on medicines that are worsening your likelihood of falling or of tremor or of stiffness or slowness or contributions to other problems. When I see patients coming in with dementia or with cognitive impairment in general, one of my big things is to look for other contributors that are treatable that might be contributing. The most common of those are mood symptoms. So I'm calling it undertreated depression, but it really a whole host of different mood symptoms that eat up potential resources and prevent people from having full cognitive capacity. And these are things that can get better with FDA-approved medications like antidepressants and things in that family. Sleep issues are super common in Parkinson's disease. Some of these can be treated with a wide variety of interventions, including CPAP for obstructive sleep apnea, but also things like cognitive behavioral therapy for insomnia. There's a lot of potential good and a lot of potential treatments out there that can improve people's cognitive state, even in the setting of dementia with Parkinson's disease, if they have these comorbidities or these other conditions uncovered. And then finally, reducing the negative toxic side effects of mind-altering medications is a big management strategy for us as well. These are some common medications that have common cognitive side effects, and that if you see a Parkinson's doctor regularly, they'll be looking at your list to make sure that none of these are causing a problem. So I'll wrap up there and just say that there's a lot we don't know about how to classify and how to study cognitive impairment in Parkinson's disease, but that also should mean that there's a lot of potential for rapid improvement if we can solve some of these particular knowledge gaps. Cholinesterase inhibitors, generally, as a clinician, I would say those are my first line management approaches for this condition. It's worth talking to your doctor about as well. With that, I'll just say this is our U of M movement disorders group. I'm proud of this group, also proud of our VA group where I work as well at the Ann Arbor VA, and happy to take any questions.
Thank you so much. That was great information. One more time, Dr. Kotagal, thank you. Nobody's asleep, right? Was the food okay? Yeah? See those cookies yet? Okay. I don't hear you. So you know what's next? Speech. Yay! All right. I would like to introduce Lisa Miodowski. I'm sure I screwed up that last name. But Lisa, she kind of joined us at the Michigan Parkinson Foundation, through Deb's several months ago, and working with speech, and she has clearly emerged as just a fantastic leader in this area. So I am very proud to introduce Lisa, who is going to talk about speech.
Oh yeah, they're there.
Is that good?
Yep. Perfect. Thank you.
Are they good?
Okay, we're good. Hi, everybody. This is a lot of faces out here today. My name is Lisa Miodowski. I'm a speech-language pathologist and owner of Speech Empowerment Solutions. And I'm also an exercise coach for Michigan Parkinson Foundation, teaching boxing classes and our Mind Body Boost class. We got your bodies moving a little bit earlier today, and now we're going to get your voices moving. I am certified in Speak Out as well as LSVT Loud. So today we're mainly going to focus on those Speak Out exercises. So just very briefly, voice is more than just the sound that comes out of our mouths. It's the way we participate. It's our connection with the people around us, and it's a part of our identity. And one of the most frustrating things that happens often with Parkinson's is that voice becomes quiet, and it becomes difficult to be heard. But the good news is your voice didn't go anywhere. Your voice is still there. We just need to give it a different cue to bring it back out. So what I want everyone in this room to do, and I can't wait to hear this, is in your normal voices, I just want you to say this phrase that you see up here. Hey, wait for me. Everybody all together, here we go. Hey, wait for me. Nice. Now what I'd like you to do is put a lot more effort behind it, and I want you to say it like you're trying to have somebody way on the other side of the room hear you. Let's hear it again. Hey, wait for me. Did you hear that? Would you say you decided to be louder? Exactly. So that decision, that intentional effort to increase the loudness of your voice is what we train. So very briefly, before we get into our exercises, I just want to talk a little bit about what exactly is happening in Parkinson's disease. You have these two motor systems. The extrapyramidal, which is those automatic motor systems, that's your walking, your talking, and your swallowing, things you don't really have to think about. In this particular motor system involves the basal ganglia and the substantia nigra. It travels through it, so it's highly dependent on dopamine. So when those signals reach the substantia nigra, they have trouble making it the rest of the pathway. So we tap into the pyramidal motor system. That's your voluntary or your intentional movements. These signals don't go through the basal ganglia and the substantia nigra, so it's less dependent on dopamine. Parkinson's has a tendency to decrease the sizes of our movements, including voice. So we tap into that intention to get that bigger voice, just like those bigger steps and bigger movements. And very quickly, one of the things that we see very commonly is what we call hypokinetic dysarthria. These are these changes that you recognize as that softer voice from those smaller movements. Voice may sound a little breathy, sometimes a little hoarse. Pitch might become a little monotone. Speech precision, so that mumbling may be heard or that slurred sounding speech. And then rate of speech, that quickness. Sometimes we have real quick bursts of speech or sometimes speech is hard to initiate. And lastly, that self-perception, that sensory piece. Oftentimes, people with Parkinson's don't recognize that their voice is very quiet. And you, as care partners here, sometimes get frustrated with that. So what we need to do is bypass those automatic pathways, tap into that intentional motor system, and sort of recalibrate the brain for using more effort with speech. So let's give it a try. This is the fun part. We're going to start with these may, me, my, mo, moos. But what we're going to do, we're going to stretch those sounds out a little bit. That may, me, my, mo, moo. It's slowed down, it's extended. So I'm going to have everybody here do this all together. Here we go. May, me, my, mo, moo. Nice. Now I want you to put that effort behind it like you did earlier today. Let's hear it a little bit more effort. May, me, my, mo, moo. That's the voice that I want to hear. Nice. So this particular exercise just sort of prepares your muscles for speech, gets everything warmed up. We do this in therapy and in our classes just to reinforce the use of intention and build consistency with intention. The other thing is using that M sound, that consonant sound with a vowel, just gets a little range of motion going in your mouth for more precise speech. Our next exercise is what we call sustained phonation. We take that ah sound and we once again stretch it out and hold it out strong and steady. So what I'd like everyone in this room to do is sit nice and tall. You're going to take a nice breath in, and you're going to hold out that ah sound, okay? Everybody ready? Deep breath, and good. Oh, I hear you still going over there. I like it. Once again, more intention, project those voices, and let's hear that ah again. Lovely. I love it. You guys don't know what you sound like up here. This is amazing. So this particular exercise is part of what it's doing is getting better closure of your vocal folds. Those are those little muscles that vibrate together when you speak to produce sound, and also increasing the pressure underneath those vocal folds. This can also help with better respiratory coordination. It may also assist with some swallow function in the way that if you get better closure of your vocal folds and better pressure, that can improve your cough strength. So with a stronger cough, if something does happen to get in your airway with eating or drinking, it's easier to cough it out with that stronger cough. Next up, these are always fun. These are our pitch glides. Exactly what it sounds like. You're going to glide your voice from a low pitch all the way up to a high pitch, just like a beautiful singer. And then we're going to glide from that high pitch back down to that low pitch. It sounds a little bit like a ah. Once again, remember to use that intention, increase that effort behind your voice, and let's give it a go together. Here we go. Beautiful. Now we're going to go from that high pitch back down to that low pitch. Here we go. Nice breath. Lovely. There's some singers in here. I know it. Let's do this one more time. Low pitch to a high pitch. Perfect. And once again, high pitch back down to that low pitch. Wonderful. I think I hear some voices I recognize. In this particular exercise, the vocal folds are just getting gently stretched, so it's improving that vocal flexibility, and it can help prevent that monotone speech that we hear sometimes with Parkinson's. And overall, it helps to strengthen the laryngeal muscles for helping to produce that louder, clearer voice. And then there have been some studies that have shown that these particular exercises may be beneficial for swallowing, that glide where you're going up and down that pitch scale moves, it improves what we call hyolaryngeal elevation. That's the forward and upward movement of your larynx or your voice box, which is very important for airway protection when you swallow. Also, it may improve the contraction of the pharyngeal walls and the base of your tongue, which is the back of your tongue, to reduce residue when you swallow, basically making a little bit of a stronger swallow. And then there are some studies that have shown that these specific exercises with Speak Out and LSVT Loud overall help with neuromuscular coordination for swallowing, so just that coordination for swallowing. So the next thing that we start to do is we start to layer in that cognition. When we speak, speaking is not a single task, right? It requires a motor effort, but it also requires cognitive effort to think of a response, to say what you're going to say, putting that all together. So we start to blend in these simple cognitive tasks. The first one is counting from 1 to 12 by threes. Once again, what we're going to do is do those first three numbers elongated, a little slower, and connect all those sounds. So it sounds like a 1, 2, 3, and so on. We're going to do this all together. Here we go. Nice breath in. 1, 2, 3, 4, 5, 6, 7, 8, 9. Pause. 10, 11, 12. Nice. We're going to count backwards now, once again, by threes from 12 back to 1. Don't forget to throw that effort behind your voice using that intentional motor system. Here we go. Let's start at 12. 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. I wish I could record you guys. This is fantastic. So there are other little activities that we can do just to get that cognition layering into it. When we start to layer in the cognitive piece, we start to improve carryover because conversation does require both that, as we said earlier, motor effort and cognitive effort. The next thing we do is we start to layer in intent into everyday communication. These are the things that we say every day. Good morning, good afternoon, how are you, where's my coffee, what's for breakfast? Those sorts of things. And then we move on from there. So why are we even talking about this today? This seems like a simple task, right? Sounds pretty easy, but the impact that it has is not as simple. So for our movement disorder specialists, approximately 90% of people with Parkinson's disease will end up with speech changes at some point in their disease progression. Early referral matters, and speech therapy is a very underused therapy compared to PT and OT. We're missing a lot of our early intervention. Many patients are not referred to us until they're having more severe changes with the speech, swallowing, and cognition. It would be great for me, I'm more about prevention and maintenance versus treatment, so I always recommend early referral. For physical therapy and OT, the same principles that you use for movement, those big movements, amplitude training, intensity, repetition, those same principles apply to communication. For speech therapists in the room, our speech language pathologists, when we consistently train intentional effort, We don't just improve the volume or the loudness of speech. We improve intelligibility, confidence, and participation in daily life. For those of you living with Parkinson's, you just felt your voice. You felt that clarity, you felt that loudness. Your voice is still there. You just need a different cue. And just to wrap things up, once again, Parkinson's may change your voice, but it doesn't take it away. With the use of intention, that intentional effort, you can restore connection, we can restore participation, and give back the power to be heard. And here we have just a couple of pictures of some of our members having some fun in our Mind Body Boost class with Michigan Parkinson Foundation and our exercise classes. Thank you very much. Have a good day.